So I got to PA school and I was like, now it's different because now you're learning to save a life. You might be the last thing between, life and death for a patient.
Hi, everybody. Hi, welcome to eShadowing, everyone. Hello, happy Monday, everybody. Hi, guys. So, as you all may know, I'm Rodalyn, and I'm here with Archana Patel. She is an urgent care PA based in Hawaii. Thank you so much, Archana, for coming on tonight.
Hi, yeah, thanks for having me.
Thank you. Can't wait to learn more about you and your PA journey. So we're going to get right into it. First, of course, we want to know about your path to becoming a PA, why you chose the PA career, and everything you did to prepare for PA school.
Yeah, so I'm Archana. I've been a PA for 3 years. My path to becoming a PA was a little long. So I did my undergrad. I'm from Georgia. I did my undergrad degree in biology, and then I applied to PA school, didn't get in, and so my next thing was to gain patient care experience and basically like retake courses, take more upper level courses. So I had a couple of gap years where I did that. And then, and I had also done, so I had a couple of gap years first, I'm sorry. And then I applied and didn't get in. So I did a 1-year master's program at Purdue, and that was a master's in biology as well. So it was after that program. I worked as a research assistant at the IU School of Medicine I was there, I think, for like 8 months while I was applying to PA school, and then I got in the second time. So a lot of lessons learned between the first and the second time. As far as patient care experience during or for PA school, I was a pharmacy tech before PA school. So that was the bulk of my patient care experience before school.
Nice. Okay. One thing that stood out that you said was that you went and got a master's in biology, you said?
Mm-hmm.
So was getting was doing the Postbac program, do you think that helped you also that helped strengthen your application?
Yes. So mine wasn't a Postbac program. Mine was a master's program. So kind of different as far as like,
yeah, what's the difference?
As far as like how schools. So yeah, that was one thing that I had to learn because I thought it was all the same. Like, you get sort of degree or certificate. They're not. So Postbac programs, and the Postbac programs are common. They're common for students like myself who either didn't get in the first time and just need to boost their application academically, or for students that maybe didn't think about what they wanted to do and now they've finished undergrad and they basically need to complete a lot of prereqs. A lot of these postbac programs have many of the prereqs because a lot of them are science-based, right? So the ones that I know of, they're all science-based. So with that being said, postbac programs are typically certificate programs. So you get a certificate of completion at the end versus for me, because I was going to go further in my education and I had a bachelor's, for myself, I wanted to earn a degree at the end of it.
Oh, so you got
that's kind of how I did. Yeah. I mean, the postbac program, usually they're structured. The curriculum is structured. They already have, here's what you're going to do the first semester. Here's what you're going to do the second semester. Some of them are 3 semesters. Some are 4 semesters long. So you could be in one up to 2 years. But they're structured, and it's structured to prepare you for XYZ program in the future, which you tell them ahead of time. A master's program, I just needed my master's in biology. So that entailed, of course, taking the classes that they required, but I had a lot of options as far as what I wanted to take for my master's program. It was more so, and I did the non-thesis track. So I didn't do the extra year for the thesis. And so for that track, it's basically the first year. And I just had to take a certain number of credits, a certain number of upper level bio courses, but I could choose. So I chose the ones that I thought would benefit me the most in PA school. So it was more of me kind of doing choosing courses that I would be interested in, that I also thought would help me in PA school. So that's kind of the difference.
Oh, okay. Thank you so much for explaining that, because I was kind of under the impression that they're the same or very similar.
Yeah.
All right. So, do you recommend that for students that were denied the first time, or have a low GPA, or have a lot of science classes to retake? Like, who is an ideal candidate to do like a master's program or a post-bac program to strengthen their application?
I think the students that, that's maybe struggled during undergrad, everybody has life happens outside of school. Unfortunately, academics isn't the only thing that we can focus on. I wish it was, but it's not. So if for any reason, your undergrad isn't representative of your true capability as a student, I would say, of course, the cheaper route would be first maybe retaking courses that you didn't do well in the beginning, because as you probably know from applying to, like, some programs will count your retaken course as the course, like give you credit for, or count the grade that you got when you retook the course. CASPA, of course, is going to calculate everything, your F in that course plus the A that you got the second time. The school itself, when the application gets to them, they may only take the A if they are only going to consider the retake or the repeated grade for that class. So in that sense, one, I would say take, post-bac courses, not necessarily a program that's going to cost you thousands of dollars, but take post-bac courses. Sometimes you can, a life hack would be taking a look at these post-baccalaureate programs and kind of seeing what their curriculum is and aligning your post-bac, taking classes at your undergrad or your community college with that same curriculum, and so yes, you won't get a certificate out of it, but the idea is that these are supposed to be challenging, upper level, rigorous courses that should show an admissions committee, like, look, I'm not the same student I was when I failed this class my first or second year of undergrad. I've come far from that. So the biggest thing I would tell students is, academically, if you didn't come out strong from undergrad, it doesn't mean you're never getting into PA school. Two, if you don't get in the first time, it's not the end of the world. And I know it's easier said than done because I was there. But you also don't have to spend a ton of money on, a master's program or a structured post-bac program to get into PA school. I mean, with the post-bac programs, like I said, you can just look at the curriculum and see if you can get that curriculum and kind of just make it yourself, at your local college or university. And you won't get the certificate, but that's okay. At least you can show, ultimately you want to show an admissions committee, one, that your grades are trending upward, right? Everybody messes up. I messed up too. But you want to show that you can be a stronger student when you're, and that you're not the same person. And you would be surprised at how many schools really do value that. It's just that CASPA and statistics prepare us to think that we're never going to make it because we compare ourselves to just those numbers. But there's a lot more to it than just those numbers.
Right. Thank you so much for explaining that and that phenomenal ending. There's a lot more to it than just those numbers. Please remember that. Yeah. And I tell them that all the time. Thank you so much for that. So before we move on, I want to know why you chose the PA career, what stood out about the PA profession when like deciding on a career, or did you know like from a really young age that you wanted to be a PA? Like what was that deciding factor?
So no, I did not know that I wanted to be a PA. I knew I wanted to go into medicine, but I didn't know I wanted to be a PA. And so what got me into the PA profession was when I was, I don't know, it's a long time ago now, but I had appendicitis and I ended up in the ER and I was treated by a PA. So first introduction to the profession, had no idea what the role was, didn't know, who he was or what, what his capabilities were. So, but I was intrigued because he, I didn't see another provider. The one person I remembered from that entire visit was him. And I had the typical like appendectomy and all of that. So I know I saw multiple people or multiple people encountered, or came across my chart or whatever it may be during that visit. But the one person that I remembered was the PA. And so I took that as, maybe, I just kind of took interest to that. I did talk to him about just his role, and it was pretty much the same as a physician. And he had told me that he works in the ER, but he's family medicine PA full time, but he was just working in the ER for just extra income. And so that was kind of intriguing because, I mean, up until then in my family, I've only had doctors and nurses. And so I didn't know that there was this middle ground, I guess. And so as a pharmacy tech, I went to work shortly after, recovering. And my pharmacist, I was just sharing with him, and he was like, "Oh, my daughter's a PA. Why don't you shadow her?" So that was just luck. But I got into shadowing her. She was a cardiothoracic PA. So that's where I really saw like a PA in action, because of course the objective was really getting a good understanding of her role. And I really did. So as a surgical PA, specifically. So she was responsible for clinic patients. She also rounded on patients in the hospital. And then she also, performed like vein harvesting when they would do CABG, or, coronary artery bypass graft, or open heart surgery, like bypass surgery. So she would harvest the vein from the leg, and then the surgeon would prepare, and then she would be across the table from the surgeon and first assist from there. So there was this balance of autonomy, and then obviously this collaboration. Definitely in surgery, there's going to be collaboration with the surgeon. But in the clinic, she was autonomous. In the hospital, when she was rounding, she was autonomous. So that was a really cool thing to see, and now she is a urology PA, but she was my first, first-hand exposure to the PA profession. So that was really intriguing, because I myself get bored very easily. And I like to do things with my hands too, but I don't necessarily want to be in surgery for half the week, or, only want to see patients outpatient. So that's kind of how I ended up in urgent care, specifically. But yeah, I would say the versatility of the profession, being able to kind of pick up and change specialties whenever you want, no residency, no additional formal training required, and being able to practice autonomously, but you will always have the support of a supervising physician should you need it.
Yes, thank you for that. Thank you. And it's crazy that you found out, it was like forgot how to describe it, but the way that I'm going through a medical condition, and I'm seeing that's how a lot of students, their encounters in healthcare with a PA was from either a PA being their PCP, or through a family member having a medical condition. So, I'm glad everything is okay though, as far as your surgery.
Yeah.
Alrighty. So we're gonna move on to talking more about PA school. You told me you went to South University in Florida. How was PA school for you? What was the hardest thing in PA school your first and second year? And how was it transitioning from being a student, or even before that, from being like a college student, undergrad, to a PA student, and then being a PA student to a PAC?
Okay, yeah. So PA school was, it was stressful, but I think it was some of the most enjoyable years as well, I would say. Definitely more stress, but yeah, my class was pretty close. So my class at that time had 24 students in it. Now that class has grown, wow, I think to like 60. So it's grown quite a bit since I graduated. But I would say from undergrad to didactic year of PA school. So when you're, the first year, when you're in the classroom, you're learning these upper level sciences. I think what really was a shock for me was, in undergrad, we all have this tendency of studying, memorizing, regurgitating for an exam, and then leaving it behind. And that's the end of that, because nobody is going to ask you about that a year later, right? That was the horrible study pattern that I had in undergrad. And so I got to PA school and I was like, now it's different, because now you're learning to save a life. You might be the last thing between, life and death for a patient. And so that's kind of what was really different for me, was kind of changing my study habits to retain the information long-term, and understanding that every class is going to build on the previous class. And so, you can't forget your fundamentals, because you're going to need them for the next class. That was probably the biggest challenge. And then going from even didactic to clinical year, my program in particular did a good job in that they exposed us to clinical year during our didactic year. So like once my program was in quarters, so every 12 weeks, we changed courses and whatnot. So every 12 weeks, you would have like, in a 12-week period, you would have about 3 or 4 applied learning experiences, ALEs. So that's basically like a Friday afternoon or a Saturday, whatever it may be, for like 4 or 5 hours. You're assigned to like one of my clinical staff had, or one of my faculty had a free clinic that he staffed. And so we would go with him on like Friday afternoon. Everybody, it would be like a group of 2 or 3 of us for each site. But basically, you're gaining some clinical exposure, learning how to talk to patients early. You don't know a ton of clinical medicine there, but watching him do it, going in and asking questions, presenting to him, and then working things out with him. So a little bit, you're learning a little bit further than your education, than the point of education. But that was really cool. When I fully transitioned from didactic to clinical year, I would say it was really hard at first to kind of bridge like medicine to like somebody in person. It's just not the same. And, we hear all the time, like, textbook presentation, this textbook presentation, that, but some people do not present like a textbook. And, yes. but they are that diagnosis that, that you thought you knew. And so that was probably the hardest part, is kind of bridging like how I studied in the textbook to have, and then applying it to an actual patient. But that's what your clinical year is for. Your clinical year is for you to mess up. Learning how to suture on a fake skin is a lot easier than learning how to suture on real skin. I mean, it just is. And so, but those are lessons that you want to learn. Those are mistakes you want to make when you're a clinical student, still in training. Nobody will be mad at you for that. Maybe frustrated. I got yelled at in the OR for dropping my hands below sterile field, but that's okay. I mean, that's part of the learning process. I'll never do it if I ever end up in the OR now. So yeah, it's almost like a rite of passage, dropping your, doing everything against what you were told to do. You are given one job, and that is don't drop your arms below sterile field. And like the nurse was like in the corner. I didn't even know she was in the room, and she yelled across the room. So I was royally embarrassed because it was my first day in the OR, like first day. It was awful.
That's not your fault. You're nervous.
I know. You know what it is? They're probably just so tired of us. They have medical students. They have, like surgical fellows too. I mean, So, but you learn, whatever, you brush it off, you learn, you go home, you cry, nobody knows about it, and that's it. And then you wake up one day and you're a PAC and you still don't have it all together, Now I would say, like, I worked in family medicine, I worked on the military base, and I've done majority of my practice since coming out has been in sleep medicine for a year and a half. So when I transitioned, and if any of you guys have been to any of my virtual shadowings, you guys know I talk about this all the time. Like when I transitioned to urgent care, I felt like a new grad all over again. Like my supervising physician really took me under his wing, like taught me how to suture again. I mean, there's so many skills that I just lost. Reading an EKG, I hadn't read an EKG since school. Since I was in PA school. So there was a lot that I had to go back and relearn. And there are still things that I feel like, if I do a couple more, I'll be confident, but I'm not 100% yet. But that's when you pick up the phone and you call the person that you are, supposed to be working closely with and that you can rely on when situations like this happen. That's why I love our profession, because there is somebody that can help you with that. And that helps your own growth. There's nothing, if you're somebody who does not like to get that kind of help, doesn't like, that kind of feedback or that kind of collaborative nature, I would say PA may not be for you, because I think a lot of what we do is collaboration. And a lot of, roles in healthcare are collaboration on a team. So yeah, I would say coming into practice, it was just, okay, I guess it's just me now, and I've never practiced with anyone. And when I was in PA school, my husband was here for residency. He's an internal medicine doc. We both work for the same hospital system. And so after he finished residency, we just decided to stay here. He likes it. I don't think we'll be here forever, but we're here for now. So, but we both love where we work. So we're just taking it a day at a time.
Oh, okay. Nice. Because I was gonna ask, like, you're from Georgia. You went to school in Florida. Like, what made you decide to go to Hawaii? But now we know. That's awesome. Yeah, and Thank you. Thank you so much for sharing all that great information and advice, especially in the beginning when you mentioned, how you transitioned from a pre-PA student in college, undergrad, to PA school and had to restructure the way you study and learn, because that is so important. And I tell them that all the time. You're not just learning just to learn and dump. You're actually learning to retain information, to be able to practice what you learn on patients and save lives. So it's really, really important to restructure your study habits and to actually, study to learn information. That's great advice. I'm glad you mentioned that. So you said you did sleep medicine before urgent care?
Mm-hmm.
So is that also like an asthma and allergy clinic? Because they're typically together, right?
Yeah, they're typically together, but mine was not. Mine was fully sleep medicine. So the bulk of what I saw was sleep apnea. Some narcolepsy, very rare, but some narcolepsy, insomnia. But the bread and butter of the practice was sleep apnea.
Okay, wow. And that was in Hawaii. Like you moved to Hawaii right after PA school?
Yes, yeah. So I took my boards and everything in Hawaii.
Oh, okay. Wow, nice. So, what made you choose sleep medicine initially? Was that something you wanted to do, or was it kind of already had it lined up, or?
No, so sleep medicine kind of fell into my lap because I was looking for a job. One thing about Hawaii, and I think this will change in the next couple of years, but one thing with Hawaii is that it's not a super PA friendly state. We did just get so it took me about 6 months to find my first job, and even that was like a locum, so it was like a 3-month thing on the military base, and I did that for 2 years. But in between that first and second time doing it, I got the sleep medicine job so that I had something like stable, full-time type of thing. And then I would just, for those 3 months, I would scale back in my sleep clinic, and so that I could help out on the military base, just split it, half and half, because I loved working on base. Like I really, really liked it. And so I would say, for any PA, I get this question a lot about, students wanting to come out here and practice or go to school here. So MEDEX in the state of Washington now has a campus on the Big Island, a PA program. They just started it last fall. But the thing is, Hawaii needs healthcare providers. I mean, definitely, I live in Honolulu, super, super commercialized, plenty of hospitals, plenty of, good healthcare here. That's not the case with the outer islands, though. So the program is not on my island. It's not on the most commercialized island, but it is on the island of Hawaii, which is known as the Big Island. And it's the island itself is gorgeous. It's so nice. But yeah, so they're looking for students that kind of have ties to Hawaii, ultimately somebody who's going to stay and practice here. So preference is given to students, that are from here, born and raised here. But yeah, I mean, I would say with that school opening, I'm anticipating that the PA awareness in Hawaii, it should grow. Now that there's a program here, because there's always been a nurse practitioner program here, and that NPs kind of dominate Hawaii as of right now.
Oh, okay. I didn't know that. Okay, wow.
Yeah.
Well, the PA, it sounds like the PA career is growing over there, though, especially with the school that's
Yeah, I think it will. I mean, I don't know if it's because it's growing or because I just have experience now too, that it wasn't hard to find like the urgent care job, for example. And so, it hasn't been as hard. The longest I waited for a job was that first job. And that was about 6 months.
Nice. Okay, so before we transition to discussing urgent care, there's just some questions. I don't want to just ignore your questions, guys. Yeah. So someone asked, how were you able to work on a base? I wanted to know how to get involved with working to treat service members.
Yeah, so locum tenens, if you guys are like, when you get out in the world and you become these awesome PAs, I highly, highly recommend locums. The life hack with locums is So locum is basically a temporary assignment, and it's essentially a travel job. They have locum nurses. They have travel nursing, locum nursing, same thing. PAs, physicians, NPs. Almost every specialty has this. Or every profession has this. And so with locum, the hack with that is establish residency in a state that has no income tax, because you pay taxes based on where your home state is. So establish residency for like a year in a state that has no income tax, or if your parents live in a no income state, claim their house as your residency. And then just travel and get these assignments. So many companies out there. Barton and Associates, there's Comp Health. Those are two really well-known ones. I think Weatherby is another one. But anyway, these companies are basically, they're contracted by the government to find staffing, i.e. PAs, whatever their needs are. They're contracted by these companies to find them. And so with that being said, they're going to try everything they can do to get you on, right? And with locums, your housing's paid for, your car is paid for. There's usually like a meal stipend. What else? Your flight. You're not paying anything. You're going there to work and everything's paid for. There's no losing situation as far as I see it. But the biggest thing is the taxes can kill you because you're going to be you also make a little bit more when you're a locum provider, because essentially you're picking up your life for X number of days or weeks or whatever to go. So I think it's usajobs.gov is so that's any government type of job, which would include military-based treating service members. Any government type of job would be posted on usajobs.gov, which I can drop here.
Thank you. Yeah, and if they don't want to cover, living or travel, then ask for more money.
So that's how you do it.
Like that. Yeah, because that's what I had to do.
Yeah. They need you more than you need them. Most of us, when you take a locum job, unless it was what I had to deal with, which was I just didn't have anything else. So I was okay with whatever. But even then, I did negotiate. They ended up paying our rent for those 3 months, even though I was a Hawaii resident. And so you can negotiate. They need you. And a place like Hawaii, they're not going to find somebody to get licensed and all of that, or even come all the way out here. So, that's the other benefit. If you want to move to Alaska, where they can, they're not going to get many people out there, you might have a lot more in your favor.
Right. Exactly. Okay. So someone asked about your studying techniques while in PA school. What advice could you give?
So I recommend studying. So I recommend studying by yourself and then studying in a group. Group studying is great because somebody can bounce ideas off of you, and you can learn from them. They'll learn from you, and kind of talking it out or writing things out as which you would do by yourself, and then talking those out. It just kind of places that emphasis again. There's so many ways to study stuff in PA school. What I found worked best for me, and I will say majority of my studying was independent. I re-listened to lectures. I recorded every single lecture. I took notes during class, but you're always going to have those moments where you're on Instagram or whatever, you get distracted. So I would go home, re-listen to those lectures, and then type out all the notes, make sure I didn't miss anything. And I realized how OCD I was when I did that, because I would go back and re-listen for every little word, which is not necessary, and it is a waste of time. You don't need to do that, but you could definitely re-listen to lectures, reiterate the point. And then I would make outlines, or kind of cliff notes. So for I don't know, strep throat, I would list out the criteria, FALE, and talk about figure out what each criteria is, and find a way to remember that. And then you're condensing a lecture that's this big into 1 or 2 pages of notes. And then it was those notes that I would make sure I knew well before I went into a study group. And so you're getting multiple emphasis Record it once in lecture, you're going to re-listen to it when you go home. You're going to create your own like condensed version, and then you're going to go talk about it with your classmates. Like that's 4 times you're going through the same stuff. So, and you're remembering that, this could lead to this, and you recognize those patterns as you get more further and further into it. And it's not like, when you learn about, for example, rheumatic heart disease, when you learn about heart disease, they're gonna remind you that, oh yeah, remember when you learned about strep and how untreated strep can lead to this? So they're not gonna just completely ignore that part thinking, okay, you'll eventually make the connection. I mean, that'll be part of your lecture too. So then that just jogs your memory all over again. And that's why I like listening to lectures. That's why I like re-listening. Always remember to be respectful whenever, even in undergrad, if you do record lectures, just make sure your lecturer knows you're recording them. Some people don't like to be recorded. So just make sure that they're aware. Yeah. And turn your phone on airplane mode, because if anybody calls you, they're going to ruin it for you. So I learned that the hard way many, many times.
Thank you so much for that. Yes, repetition is key. Thank you. Okay. So let's see if there's any more. Sorry, guys, I'm only kind of answering questions due to time relating to just kind of Archana's journey and urgent care. Well, we're going to move on to urgent care. But yeah, just general questions, just please email me or DM me. So before we move on to urgent care, I just want to put your Instagram or social media and website in the chat so everybody, is able to connect with you, and especially be able to get on your virtual shadowing platform, because they're always looking for shadowing opportunities.
Yes.
Thank you. Thank you for typing that.
I just shared mine. I just did one last week on Friday. I did a trauma surgery one. I used to do them every week, and then things just got really busy with the mentoring. So I haven't done it recently. I do have a few lined up that we'll be scheduling. But certainly, yeah, if you have any like PA school related questions at all, or just life as a PA or anything at all, always feel free to reach out to me. I post everything on my Instagram, so there's just everything's in one place. And I do mentor students. Not every student needs a mentor, though, from beginning to end. So if you feel like you're that student, certainly reach out to me. But don't feel like you can't do it on your own. I mean, we did. There was no resource out there when I was applying. So. You can definitely do it on your own too. You don't necessarily need a mentor, but I'm here if you need me.
Thank you so much for that. Thank you. So, okay, we're gonna move on to urgent care. Do you want to discuss a little bit about sleep medicine, or do you want to just jump into urgent care? It's up to you. I
can do urgent care. I think there's just more.
Okay, awesome. Okay, awesome. So, can you tell us about, urgent care, day in the life, from when you clock in to clock out, your hours, if you ever work weekends, holidays, how everything works in urgent care?
Yes. So urgent care, just similar to an emergency medicine, similar to an ER contract, you about 14 days a month. Shifts are anywhere from 8 to 12-hour shifts. And my shifts, the way that my company is structured is we work 12-hour days. And so you are a solo provider in your urgent care. So 8 to 8, we're open. And, we see anything and everything, right? And so I'm contracted for 14 shifts a month. I usually work anywhere from about I would say 18 to 20 days a month. And I can scale back, as I want to, but while I'm still new and wanting to learn, I try to get myself in there for about at least 18 days a month if I can. So my company has 6 clinics. We do rotate between the clinics, but more recently, over the last couple of months, they've tried to establish these home clinics. So now I am pretty much at the same clinic. And this is all particular to how my urgent care functions. Every urgent care is different. If you're in a rural area, you might have, a CT scanner or, labs on site. We don't have any of that because we have plenty of healthcare on the island where we don't have to worry about being the only person that X, Y, and Z patient may see. You know, there's no shortage of healthcare, at least on our island. So for that reason, we do have X-ray. We do basic testing in the clinic, so flu, strep, COVID testing, but COVID we send out for the results. But what's a day in the life like? It's hard to say.
Okay,
Every day,
nice.
no 2 days are the same in urgent care. You walk in and you might have somebody waiting for you already in the morning, or you know, you might not have anybody for a few hours. Some days are super busy, some days aren't. I would say on average, my clinic in particular, on average, maybe sees about 20 patients on average. I mean, most of the days, I would say recently it's been a lot slower, but if you're looking at average, when I first, like the first 6 months, it was about 20 to 25 patients. So still not horrible. To contrast, our busiest clinic sees, you know, 40 to 50 a day usually, and every clinic, like I said, one provider. So as a PA, and this varies in every state, but the state basically determines where your supervising doc has to be. So for the state of Hawaii, my supervising doc has to be a phone call away, but he doesn't need to physically be in clinic with me. He doesn't have to see patients after me or anything. So since I graduated, I've only practiced on my own. I haven't had anybody seeing patients behind me or anything. So we, you know, types of cases that we see, think of an urgent care as a medium between a primary care's office and the emergency room. My job is to figure out, can what you're presenting here with, one, can I treat it and you'll be fine after treatment? Two, do you need to follow up closely with a primary care or a specialist later in the week? I also can't do referrals from the urgent care. So, you know, do you need to see your PCP either to follow up with them or get a referral? Or three, do you need something done right now? And either it's a weekend, so I'm not going to be able to get you outpatient scheduling, or maybe labs won't come back quick enough, or it's a weekday and it's just an emergency and you need, you know, we're not going to waste time doing labs or imaging because the ER is going to do it, because that's where I think you need to go. So with that being said, you know, people come in to have earwax removed. That's been there for weeks. People come in for, you know, sore throats, chest pains, of course, lacerations. My clinic in particular is really close to a lot of the beaches that have the higher surf. So it's also, you know, a surfer's dream, many of the beaches that are near my clinic, but that also means we see a lot of injuries. Like majority of my patients are injury patients, whether it's, and hiking obviously is huge in Hawaii, and we are surrounded by a lot of ridge trails in my clinic, my location in particular. So a lot of, you know, sprained ankles, sprained feet, fractures, super common. So I didn't know how to splint extremity, didn't know how to like reset a joint or fix like a dislocation, that kind of thing. These are all things you learn on the job, you know. And when I transitioned to urgent care after sleep medicine, it was really hard. I mean, I told my supervising physician and when I interviewed, I did tell him, look, you know, I haven't been in urgent care, I haven't done a lot of this stuff in a long time. They understood that. And I think that's really, really important, because as a PA, we're trained as generalists, but like any specialty, if you ask a cardiologist about a skin mole, I don't know how much they're going to be able to tell you, you know, right. But ask a dermatologist how to read an EKG, you know, and with PAs, the nice thing is we can go from specialty to specialty. So a lot of our knowledge sometimes can be updated if you've changed around a lot. And so, I told them that they were willing to work with me. That's not the case with everything. My experience with this whole urgent care thing has been nothing short of fabulous. I worked with my supervising doc the first month. So he helped me kind of transition into it. So taught me how to suture, learn how to place IVs. Our clinics in particular do not have nurses in the clinics. So I work with 2 MAs, and then there's 2 front desk staff that check patients in. That's it. So at a max number of people in my clinic is 5. And so there are no nurses. So if you need an IV placed or you need something drained, like cut and drained, and cut and drain is a procedure that a provider would do anyway, even inpatient, but something as simple as an IV, a nurse would do it in different settings, right? In my urgent care, I do it, but I appreciate it because it keeps my skills up to date. So I do kind of like, some days I'm like, I wish I had a nurse here that could just do this IV so I wouldn't have to spend time on it and could tend to, you know, other patients. But then other days I would say more often than not, I'm appreciative that we don't, because that means I get to keep my skills up. So I do like that. It's also one of the more challenging things. Sometimes I do have to YouTube how to put an IV in if it's been like 3 months. That happened to me a couple of weeks ago, but you know, it's just muscle memory. So you do it once and you know, you'll eventually figure it out. Yeah, you learn on the job, and that's it. The biggest thing is showing confidence when you're with the patient. Don't let the patient, you just think about you being on the other side of it. You don't want to be the one in front of somebody that's like, yeah, I'm not really sure. You don't want to be that person. So don't make people like that.
Right.
And if you're really not comfortable, you can send patients to the ER. You shouldn't unnecessarily, but you can if you're not comfortable, if it's beyond what you think you can do.
Right. Exactly. Thank you so much for that. Yeah, and I was gonna ask, like, what's your typical patient population, but I think you explained that greatly with the explaining how there's a lot of beaches nearby, and you see the type of injuries that you see. So thank you so much for discussing that. Awesome. So let's see if we have any one or two questions to answer before we move on to the case study. Is healthcare more expensive in Hawaii because of the isolation of the island? That's a really good question.
I don't know if healthcare is more expensive here. I mean, it's hard for me to gauge because, like, in an urgent cares are more expensive anyway. But I don't feel like it's more expensive. I mean, I don't think so. I mean, at the end of the day, every even a primary care provider, right? When they're contracting with insurances, they're going to be negotiating their rates with insurance. And I mean, insurance is insurance everywhere. And so our biggest insurance carrier, for example, is HMSA. And that's like a company affiliated with Blue Cross Blue Shield. It's like Blue Cross Blue Shield for Hawaii. And so, I don't think it's necessarily more expensive.
Okay. Awesome. Thank you for that. And somebody wanted to know, what was the name of the school you said that's going to be opening up in Hawaii?
Oh, it's MedX. And they did. I'll put that right here. Okay. So their main campus is in Washington State, and they have a campus here. Yeah.
Thank you so much for typing that in. All right. Awesome. Okay, let me see if I can answer if there's any more questions to answer. All right, so we're going to move on to the case study. Thank you so much so far for being amazing.
Of course. Let's see. All right. I had this case a few months ago, and I thought it was a good one to share with you guys. So a 28-year-old female comes into the urgent care clinic. She has abdominal pain. And
I'm sorry to interrupt. Can you put it in full screen?
Yeah, I can. I guess I can't see the questions or anything, but you'll be moderating them. Okay. Yeah, that's fine though. I don't mind. I just won't be able to see anything else. Yeah, that's fine. I can do that.
I'm sorry. The chat box that they're the chat box that the students are responding.
Yeah, yeah. So when
I'll control that. No, okay. I'm watching that. Yeah, don't worry about that.
Okay. Yeah. So 28-year-old comes into the clinic. She has abdominal pain. She's concerned about a urinary tract infection. So we bring her back, and these are her vitals. Blood pressure is 128/84, respiratory rate 18, pulse 60 beats per minute, temp 98, oxygen 98. Last cycle was 10/30/20. So I saw her, I want to say it was like 2 or 3 weeks after this. So her last cycle was less than a month prior. Her pain scale 7 out of 10, abdominal pain. So that's a pretty significant pain. When I explain to patients, and you guys have all probably seen this at some point, like the smiley chart, the chart of smiley faces kind of rating your pain. 10 out of 10 is like I'm dying type of pain, right? And hers was 7 out of 10. So pretty significant. And then the rest of her vitals, so not too, impressive or concerning. So in order, these are her current medications, just ibuprofen for pain control. Her allergies, she has no known allergies, and this is medication allergies, and or other allergies. Past medical history, meaning, high blood pressure, diabetes, any health problems, basically. None. She's young. And surgical history, she has not had surgery in the past. So history of present illness. This is subjective data. So this is the first part of your note when you're a provider. So SOAP, the SOAP note. First part is subjective data, and that's this history of present illness. That's basically a documentation of your conversation with the patient. It's what the patient tells you, their symptoms. So there's no like labs involved here. There's no nothing. It's just the storytelling. When you go to a doctor and you're telling them what's wrong, it's documented in the subjective part, and it's called the HPI. So she was telling me there's a sudden onset of sharp cramping, abdominal pain, and pelvic pain, 7 out of 10 since 3 p.m. that day. Mind you, this patient, we close at 8. She came in around 7:45 that day. So since 3 p.m. that day, she's had this 7 out of 10 pain, associated symptoms, nausea, vomiting, cramping, blood in the urine, dysuria, discomfort when she's peeing or pain with urinating, burning. And then she's been spotting for 2 weeks, and she said that her OBGYN has been monitoring her for the spotting. It's happened before. So her OB's looked at it closely. Her OB's already seen her for the spotting. She had a really bad UTI in January, and she was hospitalized for it. She said she feels the same. So January of 2020, and I saw her in November of 2020. So she was hospitalized and feels the same. So clearly she has a history of these like nasty, urinary tract infections. No new sexual partners, no chance of pregnancy. She's not on birth control, and no history of STI, sexually transmitted infections. And then she denied all these, pertinent symptoms that I asked her about. So fevers, chills, rigors or shakes, flank pain, bilateral, basically pain over the kidneys on your 2 sides, urinary frequency, and urgency, and then pain. Dyspareunia is pain with intercourse. Sometimes that can suggest pelvic inflammatory disease, which needs treatment right away too. You can be hospitalized for that. But the most common cause in a female her age would be gonorrhea, chlamydia. So important to make sure that dyspareunia is also not a part. And she didn't. And then any bowel changes, are you having any like diarrhea or constipation, anything like that, any changes in your stool? Physical exam. So this is the objective part, S and then O, objective. This is all documented in the physical exam section of your note. And this is what you examine on the patient. So now you have what they told you versus your exam. This is objective. And then there's the objective data too. So labs and things like that all fall into objective, the objective part of your note. So general appearance, non-toxic, alert and oriented to person, place, and time, meaning she can talk to me. She's not in distress, other than the pain, but she doesn't look toxic, like she needs help and needs like an emergency room right now. Her skin was normal, no rashes. Respiratory, cardiac, everything was good. Abdominal, she had normal active bowel sounds in all 4 quadrants. So the abdomen is divided into 4 quadrants. If you guys have ever seen that chart, if you haven't seen it, I would Google, 4 quadrants of the abdomen, and there are charts on there that can tell you what the most, and you can't anchor on this, but it can tell you what the most common cause of pain in that area could indicate. But don't be the WebMD, the WebMD diagnoser or provider before you see the doctor with that chart. No CVA tenderness. So this is where on the back where the flanks are right over the kidneys, you kind of, pound the kidney with your fist. You put your hand on the patient's back, and then you pound the back of your hand with your other fist. And if that elicits pain, that CVA tenderness closely correlates with kidney stones. And she didn't have any CVA tenderness. And then she was severely tender to palpation in the right lower quadrant. So again, if you're, looking down at your own body, your belly button, so to the right of your belly button, kind of like that square if you divide your abdomen into 4. And she was guarding, meaning she was putting her hand over the area. Like every time I was trying to palpate, she was trying to like block it. Positive Robsing sign, obturator, psoas, and McBurney point tenderness. We'll go through that in the next slide. Genital urinary exams or like a pelvic exam, she declined. The reason I offered her a pelvic exam given her symptoms, was the spotting. You know, even if the OBGYN is looking at it, the point is that she is now seeing you. You can't just write it off as like, okay, OB's taking care of that, so I'm not going to worry about that. She has a specialist already. No, because if anything happens, you were the last one to see her. So to overlook that completely, you know, you're asking for trouble there if something happens. So, but she declined it. She didn't want a pelvic exam. And then psych, everything was normal. So what do these signs mean? Robson signs. So palpation of the left lower quadrant causes pain in the right lower quadrant. So you push down on the left, you can feel it on the right. McBurney's point is when you look at your belly button and you kind of go diagonal down to the right, it's 2/3 of the distance between your belly button and the top of your pelvic area. 2/3 of the distance there, McBurney's point. Obturator sign is when, you know, the patient's lying down and you kind of rotate their thigh inwards, the right side, and that causes pain in the right lower quadrant. And then psoas sign, they lie on their left, and then their right thigh is pulled backwards. So for this, I have them just literally, you know, lie onto their left side. I hold their back and then I pull their right leg back. If that causes pain in the right lower quadrant too, that's a positive psoas sign. So each of these signs, do you guys know what these signs mean?
Yes, there. A lot of people in the chat are saying appendicitis.
Yep, exactly. So obviously appendicitis is on the differential given this presentation, right? The next thing, objective data. So urinalysis, protein, so a little bit of protein in the urine, ketones negative, blood in the urine. Again, she was spotting too, right? So blood in the urine, whether it's vaginal spotting or what she thinks might be vaginal, it could just be blood from the urine, because she said there was no blood in the urine, right? But there is blood. And then leukocytes plus minus, so barely. Leukocytes are white blood cells. Barely any leukocytes, and the nitrites are the other one. So leukocytes and nitrites, when those are positive, you're thinking UTI. Leukocytes, nitrites, and then blood in the urine, typical for UTI. But nitrites are negative, leukocytes plus minus. So it doesn't mean that there's not an infection brewing there, but that without looking at the HCG on the bottom, the urinalysis alone, that's kind of, I mean, for a UTI that's kind of just starting, that's pretty unusual that she would have that much pain just from a urinary tract infection, which is what she thinks it is, right? And then the same patient that denied any kinds of pregnancy and things like that. Well, I ran a urine HCG on her because it's not that you don't trust her, but she is spotting. Again, you cannot overlook the spotting in any young female that is able to bear children. You can't overlook a complaint of, spotting if her period was just a couple weeks ago, spotting plus abdominal pain. You just can't ignore that. So next, you want to make sure that she's not pregnant and you're not looking at some sort of extra uterine pregnancy. So we did a pregnancy test on her. She was positive. So differentials, what are the most likely, so possible diagnoses, right? Differential diagnosis means what's your list of, 10 or 12 things that you're going to think of that could be wrong with this patient. So you're going to think about it in most likely to least likely, as well as most life-threatening to least life-threatening in the urgent care. So like I said, your mind is always, can I send her home with medication, have her follow up either with me in the 24 hours or with her primary care in a few days, whatever, or do I need to send her to the ER because she needs help right now and further workup beyond what my urgent care can do for her? So in her case, the first thing I thought of was a ruptured ectopic pregnancy. So a pregnancy that's not in the uterus that has now ruptured. Either a tube is ruptured or something, and that's causing her to bleed. Even if it's just spotting right now, it's causing her to bleed because I'm just not convinced that this is a urinary tract infection alone, given the pregnancy. And then, of course, a ruptured ovarian cyst still, though, doesn't explain the pregnancy, but could cause the spotting. And could she be pregnant and have a ruptured ovarian cyst? Sure. She could, and the ruptured ovarian cyst would cause a lot of pain. Ovarian torsion or twisting of the ovary. This is a surgical emergency, but she didn't look sick to that point. And then appendicitis, of course, and then cystitis, which is a UTI, the most benign of all of these, but still on the differential. So the most important decision, again, is what's the disposition, meaning where does the patient go from here? ER, home, where do they go? Is the patient stable enough to go? So do they need an ambulance? Do they have an option to take an ambulance? I mean, patients always have an option. I've offered EMS to many patients with chest pain who deny it, or who decline it, and then end up getting admitted for like a week. So they take themselves to the ER, but they get admitted for a week. So, I mean, you just never know, right? And it's ultimately up to the patient. You can't force them. You just have to document it. So what's the next step? Emergency room, of course, for her. So sent her to the ER. So my patient had an ectopic pregnancy, as many of you guys may have guessed. So normal pregnancy, just going through this quick. So a fertilized egg implants on the uterine wall. So 300 million sperm or so enter the vagina during intercourse. They either flow out and die in the acidic environment. Some of that sperm passes through the cervix into the uterus. The uterus also destroys many sperm as invaders. So half the sperm travel to the fallopian tubes with an unfertilized egg. And then some of the original sperm remain by the time they reach the egg. So the sperm burrow into the egg, and the first sperm to make contact is going to fertilize. In an ectopic pregnancy, that fertilized egg implants somewhere else. The most common is the fallopian tube, but it can implant in the cervix, the ovary, the tube, or even the abdomen. The embryo develops and grows in areas that are not meant to strain. The uterus, I mean, we know, right? We grow babies in the uterus. That tissue is meant to stretch and then form again, right? Shrink again. Some tissues are not. The fallopian tube definitely is not one of those. So you're ultimately going to get to a point where if it's not caught, it could rupture. And then you have bigger problems, right? So usually though, ectopic pregnancies are detected during the first trimester. And that's, it's just common with regular checkups and ultrasounds, and, or you don't know you're pregnant, like in this case, and you start having these symptoms and this kind of pain, and then it's kind of an emergent thing. And it can be life-threatening, of course, if it's undetected, because a bursting of like a tube, for example, it's going to lead to internal bleeding. So what happened to my patient? She had an ultrasound done in the ER, no intrauterine pregnancy, IUP, visualized. So they did a CT scan. They saw hemiperitoneum, meaning blood in the abdomen, but her appendix was completely normal, not inflamed. So again, this is also why you don't anchor on diagnoses, because all of those tests were positive, right? She had pain with every single one of those special tests for appendicitis, but her appendix is completely normal. But it's in the same area, right? I mean, right above the pelvic area. So she also had a 2-point decrease in hemoglobin over like that 24-hour course that she was there, which would indicate blood loss and or like, i.e. a hemorrhage, right? So they did an exploratory laparoscopy. So obviously with the two images, with the imaging scans, they couldn't really distinguish a cause. So that's why it's exploratory laparoscopy. So with a camera, small incision, go in, and they confirmed a ruptured ectopic pregnancy. So this 28-year-old girl, egg in the right fallopian tube, the tube ruptured. She got the sudden onset of abdominal pain that day, 7 out of 10 pain, not normal with the UTI. And then she had been spotting for 2 weeks though. So could this have been caught before it got to a rupture and treated with medication? Most likely, yes. It could have possibly saved her tube, right? Can't say for sure. So yeah, right tube taken out as a life-saving measure. She was discharged after being observed for 12 hours and was going to follow up outpatient with an OBGYN. The products of conception, so anything, with the fertilized egg, all of that is going to continue to shed for some time. She came to the clinic 5 days after her procedure, extremely grateful for the care she received. She specifically asked for me. This is something that I put in here because when you work in an urgent care, when you're in a family practice, this kind of stuff happens all the time because these patients know you well. You are their regular person that they go to, right? You're the go-to for every little thing for them. In an urgent care, this kind of stuff does not happen often because most of the time, just like an ER, how many people go back to the ER and thank the doctor that saw them in the ER? They don't, because most of the time you're there for one-time care and you move on and that's it. So treatment options for ectopic pregnancy, if it's bad enough, surgery would be indicated for a rupture, such as my patient. Hemodynamic instability, which she also had because her hemoglobin dropped, right? She had blood loss. And then intraperitoneal bleeding or bleeding in the abdomen. Non-surgical options for her would include methotrexate, like it's an oral medication or injection, and then non-surgical options being like a non-intrauterine pregnancy, abdominal pain depending on the degree of the abdominal pain, and or confirmed suspected ectopic pregnancy that isn't super symptomatic yet and can be managed.
Right. Awesome. Thank you so much for that case study, Archana. Thank you. That was amazing. Thank you. And especially like for going through other possible differentials, like discussing appendicitis and how to diagnose appendicitis with the test that you would do, and then discussing UTIs and other possible differentials. Thank you for teaching them that. And especially, of course, going into detail about ruptured ectopic pregnancies. And always, just you guys, always remember, any woman of childbearing age, always do a pregnancy test. I do one no matter what they come in complaining of, but especially if they have any type of abdominal pain. But I always do one because you're going to administer medicine, and a lot of these medications may be contraindicated, or their pregnancy category, to make sure it's safe to give in case they are pregnant, even if it's not an abdominal complaint. But especially if it is an abdominal complaint, always do a pregnancy test. Thank you for doing that, and that was an awesome case.
Yeah, that was it was just a good learning lesson on so many levels, I mean, initially when a patient's completely denying any chance of pregnancy, and deny not only to me, you're denying it to the MA also, right? So there's two people that have asked you, and you denied it to both people. She's pretty adamant, right, that she's not pregnant. And then her specialist has been monitoring it too. And I did see a question in the chat about, wouldn't her specialist have caught the pregnancy? And that was my first question. My supervising doc and I discussed this case because we were just so taken aback by the fact that this hadn't been caught earlier, because it's not common. It's not common that you tell an OBGYN that you're spotting and you're of childbearing age, after your period, and you don't have a history of a regular period, so it's not normal for you. It's not common, but maybe in her case, like maybe she has had a bout of spotting in the past that has been okay. And she did tell me she's had it in the past, but maybe it's more common than we knew it was, So I don't want to discredit an OBGYN either, because you just never know what she was presenting with at that time. So, or if the OBGYN told her to come in and I don't know. You never know what the conversation was between her and the OB, right? So, you can't answer for why it may not have been. But yes, I agree with you, Rodalyn, that any female of childbearing age, if you have abdominal pain, I'm giving you a pregnancy test. And this has taught me, this patient encounter alone has taught me that even when we x-ray patients, female of childbearing age, if you tell me that you're not pregnant, that's great, but I'm going to make you sign a consent form. And if you don't want to sign it, I'm going to make you do a pregnancy test. And if you don't want to do one, I'm going to send you out for your x-ray. I'm not going to do it in-house, and this is all just covering you, right? Covering yourself. So.
Exactly. Because they swear up and down that they're not pregnant. I've had that so many times, and it comes back pregnant. Like, I'm like, we so need to do this just for procedures, medications. Yes. Thank you so much. That's a great way to learn and, of course, cover yourself. Yeah. Thank you. So it's 8:08. I don't want to keep you too long. Thank you for that awesome case study, for coming on, for discussing your platform, your PA journey, everything. You've been amazing and given some great advice and gems. Awesome. Thank you, Archana. So great meeting you.
Thank you so much for having me.
Alrighty, I'm just gonna put or one more time, if you can put your social media and email contact information. Thank you.
Let me see here.
You guys, once again, she has her virtual shadowing platform. You can learn more by visiting her Instagram. So make sure to follow her and tune into her eShadowing, especially if you need more hours. Thank you so much, and I can't wait to come on to your platform. We got to discuss that.
Yeah, for sure.
Thank you. That was a great case study. She put her contact info at ap.the.pac. That's her Instagram, guys. it's about the end of our session. Make sure you guys tune in next Monday for our next session. Thank you once again, Archana. It was so nice meeting you. And thank you for sharing your journey, for giving all the amazing advice you have to the pre-PA students. Once again, I hope you have a really great day and great work day tomorrow. You're awesome. Amazing. Thank you.
Thank you so much. Thanks for having me. Bye, guys.